to practice today will be based on this short presentation. I think this is a change for better, and the candidates are the winner. The college is winner as well. So it's a win-win situation for everyone. Now, without wasting time, so my name is Dr. Mohammed Imran. I'm consultant radiologist and head of imaging, M42 Health. And I'm also medical director of the Tawam Molecular Imaging Center here in UAE. So, just a second, please. Yeah, this exam has gone live in June this year, as we know. Why was it changed? I mean, just to remove the anxiety, if you have any, that exam has changed.
Excuse me, Imran, can you go, the presentation mode, can you go for that?
Oh, yeah, sorry. Yeah, is it better?
Yeah, it is fine. Thank you.
Thank you. Thanks for. Okay, so basically, what has there may be anxiety. I mean, I mean, most of us don't like change. Let's put it that way. And the change can bring a bit of anxious moments. But to assure you, I think the college has definitely done the right thing here by standardizing the exam, because in the past, when in our time as well, there were subjective variabilities. There could have been subject. I'm not saying that there were, but there could have been, and the questions were obviously different. It could be one of the lucky days when the candidates got the cases which the candidate practiced well, and then at the same time, no two candidates were given the same kind of set of images. So to regularize or to bring more fairness to the system, this is a high quality exam. So to make it fairer, there's a change basically. Let's put it that way. So curriculum has changed as well. You must have noticed that the curriculum has changed in last year or so, or last couple of years. So to reflect the change in curriculum, the change was necessary in exam as well. To make it more relevant to day-to-day practice rather than living in the past. On-minis, no more. Very rarely you will see on-minis. They were phasing out, but now the college is making sure that all the changes in curriculum is reflected in the exam. So basically, you are not disadvantaged. What you practice in day-to-day is what you are given in the exam. So there is no discrepancy or disparity. And this exam is GMC reviewed and approved. So it's not like overnight somebody thought, okay, let's change it, And all the relevant stakeholders were consulted, including TPD school heads and, junior trainees were junior trainee radiologists formed. So it's a very well thought after exam. So now we will focus on oral exam only. I will focus on oral exam because that's my domain here, and that's the mandate. So oral exam overall format hasn't changed basically. So that has no. So there were 2 rooms. There remains 2 rooms. So you will still have 2 rooms, 2 stations. So 30-minute station remains same. Now what has happened is, first of all, when you enter the room will have new delivery platform for the oral is RISR or SS. You have that as a mock on RCR website as well. So you can have a look and play around. But when you enter the station, start your exam, basically, at the start, you'll be given test case at each session. An examiner will guide you throughout the exam. So to make you more comfortable, so please rest assured that this change is not gonna bring worse out of you. This is gonna bring best out of you. Resources are available on website, I mentioned earlier, including mock vivas. So college has made every effort to make you comfortable and well aware. Now, the contents. What is the content? So the type and level of content is not changing, first of all. So stay prepared as you are. Keep preparing as you were. And so no extra preparation is needed. All that is needed is some kind of insight and knowledge about what subtle changes have been brought in and how the exam is now being scored. That is the only thing which has been changed. And I'll demonstrate that is going to be a good thing, not a bad thing. So there's now more increase in standardization. 6 cases or patient. Let's call it patient because cases could be confusing. A case, somebody can take a case as a CT scan. No, but a patient can have a CT scan, an X-ray, MRI, ultrasound, a bone scan. So a patient can have different scans, right? So let's assume the case is a patient, okay? And a patient can have different set of images. A set of image can have a CT scan, ultrasound scan, anything. So that will be one case. So there will be 6 cases or 6 patients per oral session, or per station. So in total, you will get 12 cases in whole Viva, 2 stations, 12 cases in total. No more than that. No more than that, full stop. So if you are given 12 cases, you are doing very well, you're a brilliant candidate, you've aced it, you've gone through well, examiners are satisfied, for example, in a 30-minute session, I've shown you 6 cases. I'm happy. I'm not going to throw more cases at you, even if the time is remaining. That is the decision is made. Because once I start giving you more, then we lose this standardization. And we may give some advantage to some candidates and other candidates may get disadvantaged. So the standardization will be practiced. If you do well, you will see yourself, you'll get 6 cases, and then the period, full stop. Yeah. And so oral exam case content, each pair of examiners will show 6 cases. So again, the format is remaining the same. In one room, there'll be 2 examiners. In another room, there'll be 2 examiners. So there'll be 2 pairs of examiner, 1 pair per room. And in total, 12 cases per candidates. So what is expected is basically the images will be interpreted as normal, then relevant questions will be discussed, and those questions will remain the same for all the candidates, and the examiner will move on to the next case. And if you are ticking the boxes, you will move on swiftly. And the candidates will describe observation. Sorry, I'll just make it slightly. Okay, so yeah. The candidates describe observation, then has to follow on 2 questions that test management and knowledge. So that's it. So the examiners have been given the mandate that, okay, if the candidate is describing the observation, then ask them 2 set of questions, which are predefined and standardized, and that those questions will test your knowledge of the case you've just described and the management, whatever management the case has merits, basically. Next, moving on, the most important thing I want to discuss here is oral case scoring system. So now, these are not new things, mind you, these are not new things. Previously, if you go back to the previous exam format and if you have our presentations in the past decade, is given the presentations on different forum, and in the college website as well, it was clearly demonstrated that a candidate will be marked on radiology knowledge, and that knowledge comes into play when you see image. So if you don't know a case, you will not see. You only see what you know. You will not see what you don't know. Even if this thing is there, if you don't know, you will not appreciate it. So radiology knowledge, then observation. So knowledge is important for observation. So if you have knowledge, then you have to observe using that knowledge. And then you have to basically describe that. It's just like presenting your argument, okay, case, clinical reasoning. In the end, what is going to happen is clinical safety and management. That's we always emphasize when you finish your case, finish it properly, take it to the cleaners. So always do not forget about this clinical safety and management. That includes MDT, referral to relevant specialties, or offer some next imaging modality, what you could offer, in your domain, and so on and so forth. So now, on the basis of that, those domains are assessed, and the scoring system will be like this. So rather than giving you marks on the marking sheet, previously it used to be 1, 2, 3, 4, 5, 6, 7, 8. I mean 4, 5, 6, 7, 8. Previously it was like that. 4 was fail, and then 8 was excellent last time. I mean, in the previous exam. Now they've simplified it. Rather than giving you scores, they will just assess you and give you domain. So basically, they will give you excellent. Excellent is like previous 8. clear pass, it was like previous 6 plus 6.57. Then you have just pass, which is like 6. Previous, not current. Borderline fail and fail. So these these scores will be given to you. Excellent, clear pass, just pass, borderline fail, and fail. So each 30-minute station, communication skills are also assessed. That is the 5th domain. So we have discussed these 4 domains. The 5th domain is communication. So in 2 stations, your communication skills will be assessed separately. So in one station, one pair of examination will be looking at how you are communicating. What is your way of talking? How well you can argue? What jargons you're using, or what vocabulary you're using? How effective you are communicating your findings? You may be a good radiologist, but you may not be a good communicator. You may have aced the case, but you may not be able to explain it well to the examiner. Now that is also assessed here. Okay. So so basically, communication, you get marks on communication as well. You get marked. So what is going to happen is, in one station, you will get your score for communication. In other station, you will get your score for communication. But as we know, in one station, there are 6 cases. So what the examiner will do, for example, in communication, the examiners think that you are excellent, and they want to give you not excellent. For example, they want to give you clear pass in communication. Okay, so that clear pass will be multiplied by 6 times in that room, because they're going to give you at the end of the one station, 30-minute station, they both will discuss and say, okay, what do you think? Yeah, he was really good in communication. He was excellent, or he clearly passed the communication skills. So they will discuss and they will give you one verdict. That verdict will be multiplied by 6. For the sake of scoring system, we'll come to that. Okay. So communication, do not forget this component as well. That's part of the usually marked on that. Clarity of thought, looking for clear presentation, very punchy, focused, and organized approach. Now, this is just a case example. This is just an example, not a real case scenario. So, for example, in case one, your knowledge was excellent. Your observation was clear pass. Your clinical reasoning was okay, so you got just pass. But in the clinical safety and management, you forgot about it. You just babbling around. So you just got borderline fail. So these are on case one, these are the scoring line: E, CP, JP, and BF. Similarly, in case two, and so on and so forth. So you will mark like this. You can see there is no digit here. Okay. And after that, those marks, or those you can call that what do you call it, domain-based scoring system. These are converted to numerical values. So excellent is 4 in examiner's book. Okay, clear pass is 3, just pass is 2, borderline fail is 1, and fail is 0. That makes more sense, isn't it? Because in the previous exam, fail was 4. So you're failing, but still getting 4 number. So basically, you have messed up. You have missed big pneumothorax. Patient is killed or patient died, and you still got 4. So this makes more sense here now. Fail is equal to 0, and then so on and so forth. So excellent is 4. So, and again, don't forget about communication skills. You will be getting either 4, 3, 2, 1, or 0. Okay. So now what will happen at the end of the exam? Now here is a big change. It's a big change. What will happen in the olden ages, I would say, what would happen? Each station is scored separately, correct? So in the past, there was a possibility that you have scored brilliantly in one exam and pathetically in second station. And you fail one station and you pass one station, basically. Let's put it that way. Here you get more leverage. So you have more time to recover. So you've got 6 cases plus 6 cases, 12 cases to recover, actually. So if you perform badly in one station and you don't want to fail the overall oral component, because in olden ages, what would happen that if you got 4 or 5, it was difficult to recover overall. So in one Viva station, you got 4, and other Viva station, you got 6 or 7. Again, it's a battle. to get yourself back on the track. Now, what is happening is both of the stations will come together when marking is concerned. So you will be given overall numbers or marks. So scores from all the examiners across both stations are then totaled to give the total score of the candidate. So maximum marks is 480. If you give maximum, then it's going to be 480. I'll go back here. So if you, for example, you get 4, excellent was 4, it's going to be 480 in total. The marking framework permits a difference of up to 5 marks. So basically what has happened, sometimes human subjectivity, for example, me and my colleague, I think that you are like, excellent, and he thinks you are just like, just pass. So overall, there can be a difference of 5, any score difference of 6 or above per case will be flagged. So basically there cannot be difference of 6 per case, per patient, basically, okay? So there will not be a difference of 6. If there's a difference of 6, then this will be flagged and both examiners will discuss, and the case will be discussed basically in the meeting. So just to ensure that you don't get disadvantaged because of personal, how I feel you are, subjective variability. So they're cutting it down now. So it is a very good standardized scoring system just to help you guys, so you should be happy with this new system. The pass marks of 281, that has been calculated via a certain method, the college knows better. And then this is applied to the candidate's overall score to determine their pass-fail outcome for the oral exam. So this is good, 58.5%. So basically, in one case, one station you get 6. So out of 12, if you maybe pass 8 or 8 or 9, maybe, I think you're done. So obviously, I'm not saying that you aim for 9, but I'm just giving you a reassurance that there's a clear advantage to the candidates here. So what are the key takeaways? The key takeaways are, the exam is updated in 2025. It's a fairer system. It is definitely a fairer system, more standardized system. It will definitely give advantage to the candidates. And there is definitely clear structure marking system now. Communication, do not forget about communication. I mean, you have got the diagnosis, but to convey the diagnosis in a very amicable way is your job as well. So you will be assisted in communication. And new scoring system is aligned with modern day training. So again, I mean, it's just a flow chart or diagram. Knowledge, observation, clinical reasoning, safety and management, and add some communication to that as well. Then excellent is 4, clear pass 3, just pass 2, borderline fail 1, and then clear fail was 0. Total out of 480, you gonna get 281 marks. Once you get 281, you pass. That's it. Now, candidate 1, please.
Yes, sir.
I'll stop sharing now. Can you still see the screen here?
The same screen about the exam format.
Okay. That's been paused now. Okay. So candidate 1.
Yes, sir.
Your time starts now.
Right. Sir, I do not see the other screen. It's still the skill domains at a glance screen.
Okay. Can you see now?
Yes, I can see now. May I start?
So this patient has come to ER with acute shortness of breath.
Right, sir. This is chest X-ray frontal projection of a skeletally mature patient. This is AP semi-rect. I can see that there is almost complete whiteout of the right lung with only residual air shadows noted. There is no mediastinal shift. In my routine practice, I would change the window to see any involvement of the ribs. So I'm closely viewing the ribs to see any erosions or lytic expansile lesion. In the limited view, I do not see any significant rib erosion. So whiteout lung or opaque ipsilate right hemithorax without any mediastinal shift, I will be concerned about three things. The first is pleural effusion, a large pleural effusion, but not large enough to cause any mediastinal shift. The second would be any underlying lung mass with pleural effusion. And the third would be consolidations. I would take the case, the left lung appears normal. The heart size is normal. No other bony lesion seen. There is a line or tube noted within the right apex. So in summary, this is a case of opaque hemithorax with the three differentials that I discussed. I will confirm my findings and I'll take this case further by viewing a contrast-enhanced CT scan of the chest.
Anything else you can see on this X-ray?
So there are few nodules which are projected over the right side of the soft tissues. I'm wondering if these are artifacts because I do not see them on the left side, or maybe very faint nodules. The skin, yes, yeah, there are definitely at least 3 nodules projected on the soft tissues on the right side, and another drain is seen overlying these shadows. So may I know any history if the patient is a known case of any
Patient is not
skin disease?
Patient doesn't belong to the area, so we don't have any previous history available in the system.
Right. So these skin nodules also require further evaluation. But for now, I would be concerned about what is happening in the chest. So I'll proceed with a contrast-enhanced CT chest of this patient.
Okay.
So will you scroll, or I would want
no,
to?
I'll give you remote control. So candidate 1.
Right.
You've been given. You can accept it from your end.
Yes, sir.
Okay.
You
can scroll through your mouse, or there's a bar, scrolling bar on the top of the.
Okay. Got it.
There.
So these are the CT scan axial slices of the same patient. These are the lung windows. I can see that the lung is opacified. The left lung appears normal. I would like to see this on the mediastinal window in order to assess if there is ascites or if there is consolidation, and further evaluate my findings. I also see the same skin nodules that I saw on the chest X-ray. So again, there's redemonstration of the skin nodules.
Okay.
And
you got the remote control. Can you just a second? Let it go. Let it go, please.
G.
Let it go. There you go. Thank you.
Okay. So I'm having a little trouble with, yes.
Just a second, please.
So,
just a second. Just a second. Now, can you see this now?
yes, I can see.
You better?
Yes, I got it.
Okay.
So I'm going to scroll from top to the bottom once and then present my findings. I think I got to the. So let me first bring the scan to the.
You can ignore abdomen.
Yes, I
Okay.
know. I'm just coming to the, bringing the cursor to the. Okay. So there's a little lag in scrolling, but I'll try to fix it. So I see that this is the apex of the apical segments of the lung. So I'm scrolling.
It doesn't, okay, yeah, that's better.
Yeah. So I can see that there is right-sided pleural effusion. And there is elevation of the hemidiaphragm. Only residual lung is seen. The skin nodules were re-demonstrated. And as you mentioned, to focus on the chest only, so I'm going back to the right CP angle. So there is effusion, but this effusion appears to me slightly denser than the normal fluid, because if I compare it with the CSF fluid, it is denser than that. So now I'm looking what else could be. So there's no pleural effusion to suggest any pleural-based pathology.
So you mentioned there's no pleural effusion to suggest any pleural-based pathology.
No, so there's no pleural thickening. There's no pleural thickening or pleural nodularity, which would suggest the cause of pleural effusion. I can also see that there are some. Okay, so there's this is an arterial phase, and in this arterial phase, I can see that there's another area of. Let me go to that area. There's another area of arterial blush with the same density as the aorta.
Please, thank you.
Yeah, so let me go in. This area. So can you see my mouse?
Yeah, I think there's a lag, but
Yeah, I know there's a lag.
okay, so what is that?
This area.
What is that?
So if there is no pleural thickening, no pleural enhancement, and there is effusion, so I'll be thinking about other causes which might give a dense pleural effusion. This area of bleed may be the cause of increased density of the pleural fluid. So in a patient with who has these skin nodules, I'll be thinking about neurocutaneous syndrome like neurofibromatosis 1, which has associations of vascular abnormalities like aneurysms and pseudoaneurysms and like fibromuscular dysplasia. So my top differential would be pleural effusion due to a rupture of any pseudoaneurysm. In this case, I will immediately contact the referring physician. This report needs to be immediately alerted to the referring team, because this rupture might, this pseudoaneurysm might be leaking, and this may be a cause of patient's deteriorating condition. So an interventional radiologist may also be involved in this case for possible coiling of the aneurysm, and for further workup of the neurofibromatosis, the patient, and counseling.
Okay, so you mentioned that this might
So
be
I think
bleeding.
this is
it bleeding
bleeding
or not?
because this is this is the same density, and there is a large effusion. So this is currently a surgical emergency.
What makes you think it's bleeding?
So if I go to that area, so if so the increased density of the effusion, why would be the effusion so dense if it was a simple
You
effusion?
might have bled and stopped due to tamponade effect.
Tamponade effect.
Yeah, basically you have got certain capacity in the pleural cavity. If there's
Sir,
a bleeding,
we can see the inferior vena cava. If the inferior vena cava and the hepatic veins, they do not show early filling, then we would not think about right ventricular strain or band pressure.
not cardiac tamponade. The tamponade effect on the bleeding aneurysm itself because of the surrounding increased pleural effusion and hemothorax. But okay, that's fine. Thank you. I'll show you one quick more case. Thank you. Please let go the
Yes.
mouse. Thank you. Okay, this patient came in with abdominal pain.
Right.
Right. Just a second, please. My system is playing up a bit. Okay, let me share it with you. Have you got the remote?
I'm right now, the scan has not been projected.
Yeah, but you should be seeing it now. Can you see it now?
Yes, now.
Okay. What can you see?
CT abdomen.
Okay. That's fine. Have you got the remote control or not?
No, not yet.
Please accept it. Thank you.
Yes. Can you, sir, double flip the screen so it's okay? So I'm not able to scroll the scan. Yeah, now I can. Okay, so this is the scrolling and the so now I'm at the topmost slices. So I'll take a quick scroll at the entire set of images and then present my findings. This is a CT scan of the abdomen, axial slice, taken in the portal venous phase. The history has not been presented to me as yet. Yes,
I mentioned
thank
abdominal
you.
pain.
So, right. So the area of concern in this scan is the liver. I can see that there is right-sided pleural effusion. Along with that, there is the right hemidiaphragm is elevated. And in the liver, there is a multi-lobulated, multi-septated cystic lesion seen with peripherally placed daughter cysts. There were a few areas of calcifications in the rim. No significant contrast enhancement is noted. This is a solitary lesion. There is some mass effect on the rest of the liver parenchyma. So in summary, this lesion is a case of hydrated cyst, in my opinion. I am also looking at the rest of the scan to see if there are any other similar lesions in other organs like kidneys or pelvis. So far, I do not see any other lesion. The gallbladder was separately seen and it shows a calculus within it. There is no abdominopelvic ascites. The rest
So
of the
what do you
vesta.
think?
So this is a
So yeah, how are you going to approach it?
So this is a case of hydrated cyst. I'm looking for any complications of this. For example, a rupture into the intrahepatic biliary ducts, which I do not see. So this is an uncomplicated hydrated cyst. These lesions are usually do any biopsy in these cases because this results in anaphylactic reaction. I will immediately convey my findings to the upper GI team and inform about this cyst, and also tell them that right now there is no complication of any rupture, but this is a large size cyst, so this needs to be attended on urgent basis.
Besides surgery, any other treatment in practice?
So all I know is that we do not needle these things because this can.
Okay, thank you. That concludes the Viva. Thank you very much.
Yes.
Sorry, today is a bit shortened because initially we took a bit of time for the presentation. So, but I just wanted to touch base on that was important. So how did it go, first of all? I want to have your thoughts on it.
I think you are the better judge.
Okay, so basically you did well. Let's talk about this case first. I mean, here you were very good. First of all, before commenting on the findings and observation and all those things, I just want to comment on your style. I mean, your style is very good, but I will suggest one thing only, if to speed up a bit, because I think you are a very good radiologist. Let me say that. And your observational skills and the minute things you go into, I think it's very, very good. That's a sign of a good radiologist. But in exam setting, I would say that you need to be a bit up to the speed, basically, and quick on your toes. Primarily because then you can, I mean, with this speed, half an hour just flies by. And I want you to see 6 cases and get excellent in those 6 cases, So if you talk a lot, there may be a case that, examiner will probably rush you. Okay, let's move on. Or you may not be able to see full 6 cases, So it's better to just strike a fine balance between explaining things, as you know a lot, so you're explaining a lot to me. But at the same time, you should be wary of the fact that I need to see the next one as well. I know it in my heart that it's headache cyst. So I just don't want to expand on and on and on and on and on. I know the diagnosis. I have already told the examiner that I've seen the daughter cyst. I mean, you have spit it out. Yeah. So now rather than stretching it, just cut it short. In my word, just cut it short. Just cut it short and just move on. So you have mentioned that, yeah, it's a hydrated cyst. Yeah, it's not ruptured, no complication. I can see the vascular system is fine. No other cyst of such nature is very important. You mentioned that. I've seen that. I will look for this similar cyst elsewhere in lungs, spleen, elsewhere. I can't see. In my day-to-day practice, I will do CT thorax as well and see if there's any pulmonary cyst as well. And given the fact it's a solid cyst, these are my I'll refer to surgeons or hepatobiliary surgeons for the further course of action. These are either surgically treated and medically treated as well. But I will leave it to surgeons. These are we should not be aspirating it. That's for sure, radiologically. So you have given everything to surgeon in 2 minutes after you have diagnosed in your head or you made up a diagnosis in your mind that, yeah, it's a hydrated cyst. So don't stretch it. That I'm doing, gallstones, yeah, you mentioned, finish, move on. So these are kind of things, you just need to be quick. Otherwise, you're excellent. I mean, I'm very impressed. You have very calm demeanor. So maintain that, but just, multiply by 1.5 speed. You know, on YouTube, you play 1.5 times speed. So just increase the speed a bit. Yeah, it's hydrolysis, it's classic hydrolysis, you know. So I just wanted to give you, show you that it is on many, but on many have gone out of the window. But you may see some other things. So if you get this, you should be wary of the fact that you may see anything else as well in the same scan. So look for the bones as well. You know, check for the bones if there's anything else in the bone, or whether there's a discrete lung lesion somewhere else, or something else going on. So just look for. Just tell the examiner that you look for some any other abnormality in the scan. If there's an abnormality, he will let you examine. Otherwise, say no. Move on. You know. So next one. The first one, I will go back to that case just to for the sake of audience. I will not show X-ray for the interest of time, but we will just quickly. Yeah. So here, deliberately, I gave you this lung window. I wanted to see your response. Okay. So can you see?
Yes, sir. Mediastinal window.
Yeah, can you see that, right? Contrast enhance. So basically, you picked it up well eventually. Initially, you were a bit struggling, but then when you saw that, you know, can you see that?
Yes, sir.
Yeah, so you saw the double aorta sign. So where is it coming from? It must be a bleeder, you know, or pseudoaneurysm, let's put it that way. Now you mentioned that, you know, in these cases, patient can have pseudoaneurysm. If you wanted to go extra mile, you know, you didn't get excellent in this. You get, you know, more than that, less than that, slight less than. Why? Because it's clearly visible. Once you've seen the abnormality, see, the artery is coming off, intercostal.
Yes, sir.
That's coming off aorta, yeah? And then it has bled here, bled into the pleural
Pleural
cavity.
space.
Yeah, so there's a heterogeneous content. So I asked you a question whether it's bleeding or not. I mean, there's a heterogeneity. So simple answer is there's heterogeneity in the pleural effusion. You know, this is not homogeneously dense, or so that means, you know, there is a mix of blood, mix of different ages of blood going on. Plus, there is a bit of I think there's a bit of contrast flush here. So probably, most likely, it is still bleeding. Let's put it that way. Apart from that, I mean, I think you did very well here. You picked up nodules on X-ray. So this is a case of neurofibromatosis. Probably the presumption was this was one of my patient. The patient just probably had a pleural neurofibroma of, and then that might have eroded one arteries. That's the assumption we have made. Yeah. But the thing is, this patient came collapsed. So the key was not to drain it. Okay, not to drain it, but refer the patient to IR instantly. Because once you drain it, then it was the bleeding was sealed because of the pressure effect, tamponade effect. You will just release the pressure, and it may bleed again. So anyway, patient was referred to IR and then embolized, and patient survived. So yeah, candidate number 2. So here if you go back to the scheme, you know, so how are you gonna rate yourself now?
So you're going to judge. I cannot say anything.
Okay, so I think let's put it that way. So I would give you, if you ask me, I mean, if I would give you clear pass in the first case, and excellent in case 4, a second case basically. So clear pass
Right,
is
sir.
3 and excellence is 4. Yeah. So I would give you
Right, sir.
that.
Right, sir.
Okay. And while
Thank you.
communication wise, I will give you 3, but you need to speed your communication skill. You are very good. You're very calm, but just, you know, bit of fine tuning. Okay.
Right.
Number
Right, sir.
2, please. Thank
Yes,
you.
sir. Sir, can
Thank
you
you so
hear
much.
me?
I can hear you clearly. So let's start. Database. Okay. Patient basically. So he's come to orthopods and had an MRI. Okay.
Okay, sir.
I'll give you remote control. Can you? Yeah, brilliant.
Yes, sir, I can. So I have been provided with MRI PD fat set sequence of on coronal section. I am scrolling through the stack and then I will comment. Okay, so I can see that there is bone contusion and marrow edema along the medial tibial condyle. The lateral meniscus appears intact. On the medial meniscus, I can see that there is a high signal along the posterior aspect, along the posterior horn, and there's also minimal blunting of the body segment of the uh, medial meniscus. Rest, the femur shows is normal. There is no bone contusion. There is mild joint effusion. Um, I am looking at the ACL and PCL. The PCL appears normal, and the ACL at the tibial attachment shows mild hyperintense signal. I want to look at the ACL on the rest of the uh, section. I'm looking at the collateral ligaments.
Okay, that's for you.
Okay. I think there's some problem in the
No,
scrolling.
no. Yeah, just a second,
Okay,
please.
okay.
Let go the mouse, please. Thank you.
Okay, okay, sure, sir.
Okay, now you can scroll it.
Okay, first I'm scrolling to the entire stack and then I'll comment. I think I cannot scroll it.
Can you? These bars. Okay. Now, try it now.
Uh,
No?
there's a bit of lag in the scrolling, I guess.
Please. Let me reset the
Oh, yes, yes.
Just scroll as you
Oh,
would normally scroll.
yes, yes, yes. Uh, let me try the bar, please.
You can scroll with the mouse as well. You don't have to touch the bar.
Okay. The lateral meniscus appears normal on the sagittal section, but I can see that there is a double PCL sign on this view, and there is loss of the bow tie appearance at the body segment. There are less bow ties. So this findings are highly concerning for bucket handle tear of the medial meniscus. The PCL appears normal. I'm looking at the ACL. So the ACL shows heterogeneously hyperintense signal, which clear indicates that there is a high-grade tear of the ACL right at near the femoral attachment site, right here. The PCL appears normal. The quadriceps tendon and the patellar tendon appear normal. So overall, my findings are suggestive of bucket handle tear of the medial meniscus with the medially displaced flipped segment in the uh, at the intercondylar region along with high-grade ACL tear, I would refer this patient to the orthopedic team for further management. There's also joint effusion along with edema in the medial tibial condyle on the previous sections. So this is likely a post-traumatic case, I presume, but I would ask for the history of surgery. This needs orthopedic referral and further management by the orthopedic team.
Thank you. Okay. Yep. Okay. This patient has presented with ongoing headache for some time now. Okay. I'm just going to share with you now. Let me give you remote control. Please accept it and just scroll it as you, just a second, please. Yeah, scroll it as you would do normally. Yeah.
Okay, so I've been provided with CT brain axial sections, non-contrast. So first I would scroll through the entire stack and then I would comment. So after the first scroll, I can see that there is a large heterogeneous appearing mass lesion in the frontal regions along with significant vasogenic edema in the bilateral cerebral hemisphere. This lesion appears to be in the basal frontal region along with mass effect on the underlying ventricles, causing their significant compression and significant edema in the bilateral frontal and parietal lobes. This is also causing a mild leftward midline shift. The brain appears edematous with diffuse effacement of the sulci, and on scrolling downwards, I can see that there is a sort of an osseous density in the right anterior ethmoid region, which I would request the bone window for further assessment. There is significant sinus mucosal disease with almost complete opacification of the bilateral ethmoid, bilateral sphenoid, and also maxillary sinuses. There is also air fluid level in the left maxillary sinus and in the right sphenoid sinus. Uh, on Okay, so and I can see that there is a heterogeneous, the right jugular fossa also appears slightly expanded, which I would also request the bone window to locate on the bone window. So overall, my findings are of a heterogeneous density. Okay, so I've got the bone window. On bone window, I can see that there is complete opacification of the sinuses, as I mentioned above, and there's also a heterogeneous looking area in the right anterior ethmoidal cells. On scrolling upwards, I am looking at the lesion. There's also heterogeneous area in the right frontal sinuses, along with significant bone erosion of the frontal sinus walls. Uh, Okay, so I am looking at the right jugular fossa on this bone window to look for any So this bone jugular fossa appears expanded without any significant bone erosion. So all my findings are suggestive of an aggressive etiology at the with epicenter at the basal frontal lobes in the midline, with significant edema in the frontal lobes brain, and there is a significant brain edema. I would also take a look at the tonsils for any tonsil herniation, and there's a significant bone erosion at the basal frontal region in the ethmoid sinuses with complete opacification. So my findings would be suggestive of a lesion which could be arising from an extra dural location, which I would look at the sagittal section because this appears to be at the basal frontal. So this could be an aggressive or atypical meningioma, which is eroding into the sinuses and also with
What else
significant
it could
edema in
be?
the brain.
Candidate two, what else it
Okay.
could be?
If the patient is old, this could represent a metastatic lesion, a METS. This could be an aggressive meningioma. This could be a glioblastoma multiforme. So, can I take a look on the sagittal section if this is a dural based at the basal frontal region?
I've given you something else without you asking. Have a look at it.
Okay. So I can see that this shows a significant homogeneous enhancement and is very well defined, lobulated at the basal frontal region. So given the enhancement pattern and its location, this is likely an atypical meningioma given the very homogeneous enhancement pattern and with significant brain edema, leftward midline shift, and also concern of brain herniations. So this patient requires a referral to the neurosurgery team for further evaluation. This has significant hydrocephalus and mass effect, so this needs urgent decompression. Maybe we can put an EVD to uh, for decompression of this of the hydrocephalus, and also surgery would also be considered given significant mass effect and the bone erosions on the sinuses. So neurosurgical consultation would be my next step, and this patient would be further managed by the neurosurgery team.
So, in essence, what you mentioned that a patient has got what, sorry, meningioma
Uh,
or
an atypical meningioma.
atypical meningioma. Okay,
Yes,
thank you.
thank you so much.
The patient recently had a procedure done, okay, and now came to ER unwell, severely unwell. Okay,
Okay, sir.
just a second, please. Let me. Okay, all yours. Thank you.
Okay, sir. So I have been provided with the axial sections of the pelvis. Uh, I think this is not scrolling.
Could be scrolling. Uh, just a second. I'm giving you control again. Try again. Just a second. Let go.
Okay.
Let go, please. Now try again, please. Thank you.
Sure, sir. Okay, so it's scrolling. So I have been provided with the axial sections of CT pelvis. I can first I would scroll through the entire stack and then I would comment on the findings. So this is likely CT of the extremities. So I can see that there is non-opacification of the left-sided uh, popliteal artery with very faint opacification of the distal anterior tibial, posterior tibial, and peroneal arteries. They are very poorly opacified as compared to the right. I'm scrolling inferiorly to check their entire extent. So on right, there's also a very poor opacification of the distal arteries. If there is uh, after the scrolling, I would take at any delayed arterial phase, if any available, because of the calcific atherosclerosis, there could be delay of the contrast passage. So I am scrolling superiorly. Okay,
Hang on.
okay, sir.
I think what you've got is what we have, you know.
Okay, sir.
And that is good enough to reach a very
Okay.
accurate
Okay.
diagnosis.
Okay.
Okay.
So on this oh, sorry. Okay, on this I can see that there is significant stranding in the right inguinal region, and I can see that there is a small outpouching arising from the right femoral artery, with surrounding fat stranding and mild hyperdense free fluid. Uh, there is also an arterial blush from the right femoral artery, which is highly concerning for a bleeding pseudoaneurysm. On the right, the left side vessels appear clearly normal. Uh, I am scrolling inferiorly, so there appears to be lobulated outpouchings from these vessels with significant surrounding hyperdense fluid, likely blood. So uh, given the recent intervention on this patient, which is likely vascular, I have a high concern of right femoral artery pseudoaneurysm, which is likely bleeding, actively bleeding. So further referral to the, I would take the phone and I will inform immediately the primary physician and also the vascular surgeon. This needs an immediate attention of the vascular surgeon because the pseudoaneurysm is actively bleeding. So this requires urgent referral to the vascular surgeon for further management because there's bleeding pseudoaneurysm on the right.
Okay, that's fine. Thank you.
Thank you so much.
So, can you do your exam is finished here? How did you do?
So I think I was adequate or slightly below adequate.
Why do you think you are below adequate?
Mm, I think I missed some findings in the second case, but overall I did adequate, I guess.
Okay. So if you were given another chance in exam, what different you would do here?
I would ask for the post contrast if I have a concern of any mass in the brain, which I missed on the second case.
Okay. Let's talk about this case first, okay? Now, first of all, before even talking about this case, let me talk about your style. You are gifted in a way that you are your observation and the description is very good. You describe a lot of things in a very short amount of time, which is good, very good. So you condense your information in a very short space of time, basically, which is good. But you are a victim of your own success, I would say, because what you are doing here is you're going hard at the case, you're picking up findings, a lot of findings, and then you just assuming that okay, that's a diagnosis, move on, and then you just expand your knowledge or showcase your knowledge on that presumed diagnosis in your brain, in your head, basically in your mind. I feel that's happening at the moment in 2 of the cases. Here as well, for example. Let's take an example of this. So what are you doing is, what you're doing at the moment is, you're jumping on the positive findings you see, obvious positive finding you see. But one thing is sure, you're loaded with information, basically. Let's put it there. You're loaded with information. You're loaded with knowledge. But you need to just guide this knowledge accordingly. So you just need to hold back an exam. I think you just jump into it, deep dive into it. Just hold back a bit. A bit. Okay, look at this slice. What I want you to now think that you are again in the exam. What could you have, what is the diagnosis here? On this slide.
This could be an
Okay. Here.
can this be a fistula formation on the right?
Yeah, so yeah, on the right, so basically patient had a procedure. I mentioned patient had a procedure done.
Yes.
Patient had a right-sided cath done, right heart. So basically a coronary cardiac catheterization done through the right groin. Okay. So what happens is it's a normal complication. Then when you don't press it enough, or these days they use the sheet, or seal, and you seal. That basically covers everything. They seal the hole or puncture wound. But then in certain centers, when it's not used and old style pressure compression is done, there's a chance that it will not seal properly, and then there'll be a pseudoaneurysm. But another complication of the catheterization, percutaneous vascular catheterization, is you can create iatrogenic AV fistula, basically.
Yes.
So arteriovenous fistula. So that has happened here. Besides another pseudoaneurysm, if you go further scroll down, yeah. So that has happened. So patient has got 2 findings, pseudoaneurysm and AV fistula. So you basically diagnose AV pseudoaneurysm, and you were right. So you passed the case, but you just barely passed the case, basically. What you call it here is I would call it just pass. So you get 2 marks. I wanted to give you 4 marks the way you are conducting yourself. Apart from that, nothing is there. So the way you started the exam here, you started from here. I think you were commenting a lot on disparity between, here, the popliteal vessel, the contrast enhancement on the 2 sides. Now, I mentioned patient is really unwell. You concentrate on history. History will give you a lot of things. So patient was unwell. So, I mean, why would patient, were you thinking of some arterial dissection or thrombus here, and then ischemic lag? Or so basically, whenever you get a CT scan, just ask the examiner. I'll take a few seconds to scroll through it, and then I'll start my finding observation, or I'll start talking about it. So never ever commit to any diagnosis or even explanation before, from top to bottom. Just see the scan. It takes only 5 seconds. See, if you had seen this before, you wouldn't have commented here or wasted a couple of minutes here, So basically, see where the money is. The money is here at the moment. There's something going on the right groin. You can see this, skin puncture. And clearly patient has got issues here. So there's no point talking about down below. So that's the take-home message, that concentrate, focus. Regarding your second case, second case, you started very well. I was very happy, actually. But then what happened? I'll show you. Okay. So if you look at this, I gave you first non-contrast CT. Okay, you asked for non-contrasticity. I gave you. You basically started talking about the case on non-contrast. Sorry, it's yeah. Can you see the scan?
Yes, sir. Yes, sir,
Okay.
I can.
It keeps jumping in my screen, so that's the problem. Just a second. Okay. So if you see it, you started talking about it. You talked sense here. You said extra axial mass, somewhere around the base of the skull, and so on and so forth. And then you suddenly decide that it's a meningioma. Is it a meningioma or it's an atypical meningioma? You decided. What else it could be? Could you, you are absolutely right. The cystic change is there, then a lot of edema, the changes are going across the midline, they're going on both sides of the, and then and you yourself mentioned when you were talking about this mucosal thickening, and then, paranasal sinus involvement, and then there's a bony remodeling. I was just very happy that you're going in the right direction. And so what else? But then you wanted to ace the case on one sequence, axial sequence, and without contrast. If you get a mass aggressive lesion, without wasting time, you should ask for contrast in a scan. You never asked for it. So that was a big mistake. So I had to give you without you asking. So when you see this, clearly there's an issue here. That's the mass. Clearly it's arising from most likely paranasal sinuses rather than it's an indigenous brain mass. Clearly it's arising from the base of the skull. And you need to further characterize it. You need to have contrast in a scan for sure. Okay. So in contrast in a scan, then I gave it to you, and then you said, yeah, I can see that, enhancing. So what can you see here now? Enhancing septation between these cystic lesions, and then there's solid mass enhancing mass as well, so solid and cystic. And then if you see, it's not rising from, you can see the fox very clearly. But then if you move down, Crista Galli is gone, and then, it's going into the ethmoidal air cell area, nasal area.
Sir, we cannot see the screen.
Oh, sorry. Okay, better now? Yeah?
Not, sir, not yet. We cannot see the screen yet.
You can't?
No, sir. Yes, now we can, sir.
Okay. So basically, here you can see there is a lot of enhancement, center around your paranasal sinuses. Brain, cystic spaces, but then it goes into, clearly is going into the ethmoidal cell area, your nasal cavity. So it's a mass arising from the nasal cavity and invading through the base of the skull and into the brain, and it's got cystic spaces. So what do you think? What is gonna be? What is the diagnosis here?
So this could be esthesia neuroblastoma.
This could be, or this is.
This is most likely.
It is yeah, you are right.
Yes.
Yeah. So now then, once you say that, then you say, can I have an MRI? Has the patient had an MRI scan as well? I wanted to give MRI as well. This patient had an MRI done as well. So,
Yes.
if you had clearly described it in a right way, I would have given you MRI.
Yes.
So you missed it was a beautiful case, it's a beautiful case. I'll share the screen with you now. See, that's MRI. What can you see there?
Yes.
It's clearly coming from nasal area. Yeah.
Yes.
It's clearly breaching the base skull, clearly going into the intracranial fossa. So it's a very good case. It's a classic case, and you should not miss it. These were clear. These were easy marks for you. The first case was fine. I mean, that was brilliantly done. You got full marks. Excellent. 4 marks in it, the first case. You did it very well. You couldn't have done it better. Let's put it that way. So well done for that. That was definitely bucket and tear of medial meniscus and ACL tear as well. So those who, for the interest of audience, okay. So those who just wanted to know what was the diagnosis here. As he described, double PCL sign here, and then you lose a bow tie, you know, that's the lateral meniscus here, intact, bow tie there, and then you lose it here. That's medial meniscus gone. And then obviously, when you look at the other sequences, other views, you get the answer. For example, in the coronal sequence, not this one. Here. Can you see the screen now or not?
No, sir, cannot.
Okay, there. Can you see screen now?
Yes, yes.
Okay. Yeah, so there's a flipping of the component of medial meniscus medially, intercondylar notch here. So you can clearly see that. So that's medial meniscus, bucket and anterior medial meniscus. And then ACL has got some high-grade tear as well. Okay, carry number 3, please. Thank you.
Thank you, sir.
Excuse
Hi,
me,
Dr.
Imran. I've got an announcement to make, so just give me a minute. Imran, can you see my screen?
I can clearly see your screen, yeah.
Okay, so just a quick announcement. Next Thursday is a very special session. Don't miss it. It's a special pediatric session, and we will be honored by Dr. Catherine Holliday, the Royal College of Radiologists president. She is going to deliver a lecture on suspected physical abuse in babies, the role of radiologist. Please remember, it's a very important subject for your day-to-day radiology, and it is very important for your exam because cases of suspected physical abuse do come in the exam. We call it SPA. Please remember, we used to call it NAI, non-accidental injury. So the first part will be a lecture. She will also she will have time to take questions, etc. So it's if you want to ask her anything, she will be there. And in the second part will be after 1 hour. Dr. Mavish, she's a pediatric consultant. She will actually take 3 vivas, mixed cases, but each candidate will get an SPA case, suspected physical abuse case also, but you will also see other PEDS case. So it's a very special session next Thursday. Do not miss it. Thank you very much, Imran.
Thank you. Excuse me. Okay. It's a limping child.
Hi, Dr. Imran.
All right, I just need to share the screen with you guys.
Shall I request control? Or is it just an X-ray?
You don't need control here.
Okay. Is there an image on the screen? Because I can't.
Sorry, did you not get this?
Oh, yes, I can see it now. Okay, so this is a frontal pelvic radiograph of a skeletally mature patient. What I can see, what immediately caught up my eye, is the widening in the symphysis pubis. And I think this is suggestive of bladder extrophy. I struggle with saying this word. Looking quickly at the rest of the bony pelvis, I can't see anything that jumped to my eye. I think maybe the head of the right femur, femoral capital epiphysis is probably a bit irregular. So I wonder if there's two pathologies, and this is a bit of avascular necrosis of the right femoral head in keeping with Perthes disease. So for this patient, with regards to the bladder extrophy, I think if this was the case, it should have been picked up when the patient was a lot younger, just from looking at the skeletal X-ray. So I wonder if they have been already investigated, and a plan is put in place with creating a conduit and all this malarkey. But then if not, then I would highlight this to the physicians. Regarding the right femoral capital femoral epiphysis irregularity, if it's not very, I'm actually, I think maybe it's projectional, and it just depends on the history. So I would just ask the clinicians if there is any history of hip pain and what initiated this X-ray in the first place. Is
Okay.
there any history?
Limping child, as mentioned earlier. Initially, I mentioned limping child.
Oh, sorry, I apologize. So in that case, I think the avascular necrosis in keeping with Perthes disease of the right hip would be on top of my differential. And I would also highlight the widening of the symphysis pubis to the, in my report.
Sorry, I'm going to give you control here.
Mhm.
Just with the pointer, please let me know which area is depicting avascular necrosis here.
Like the irregularity on this area here, and a bit of like the.
Just show me. You've got the control now.
Oh, can you see my mouse moving, or is it just me moving?
No, I can't see.
All right, okay. So I will just request control from my end if that's okay.
If you can, please, thank you.
Stop remote control. No, I'm actually in control. I don't know why is my mouse not showing.
Yeah, I can see it now moving.
Okay, so I was concerned about this area here, and this a bit of the opacity here. Actually, yeah, the height itself is not very much different, but maybe it's a little bit less than the left side.
Okay, that's fine. So what do you do then?
I would highlight this to the clinicians, and I think this patient might need an MRI to confirm the diagnosis. And AVN or avascular necrosis and Perthes disease is spontaneous, and it can be bilateral as well. So to look out for the other hip as well.
Okay, what age group they are generally happening in? Which age group?
So avascular necrosis or Perthes disease happens between like 7 or 8 years old.
Okay, that's fine. Next case.
Okay.
Share it with you now. Okay, let me give you control as well here.
Yeah.
So you have control now.
Okay.
And okay, this patient is complaining of headache,
So
severe headache.
right. So this is an axial CT head with contrast. What caught up my eye immediately is the abnormality on the left hemisphere. Sorry, am I scrolling?
Yeah,
Am
you are.
Yeah,
You
okay,
are.
sorry. What caught up my eye is this abnormality on the left hemisphere. There is contrast enhancement with irregularity of the subdural space, and there is sulcal effacement with mass effect and midline shift. The left lateral ventricle is effaced or partially effaced from the mass effect, and I'm sorry, the control of the scrolling is a bit either too fast or too slow. Okay. Right, so coming back to the base, I'm just looking quickly at the circle of Willis. And the right hemisphere seems to be unremarkable. Is there any history that I can link my findings to?
The patient is new to area. He just came in with severe headache. He was visiting his family here.
Right. So basically, there is contrast enhancement in the subdural space, and it's also in the subarachnoid space, and it is causing cerebral edema and sulcal effacement, diffuse sulcal effacement, and also the mass effect that I talked about in the left lateral ventricle and the midline shift. These findings are concerning of a subarachnoid hemorrhage, and now that the contrast enhanced study is already done, I think I would discuss my findings. I would first want to know whether the patient is actually conscious and what's the patient doing, and according to that, I would basically carry on. So if the patient is critically unwell, I would contact.
Patient GCS is 14, 13, 14.
All right, so the patient is becoming unwell. I would discuss my findings with the stroke team. Sorry.
No, that's fine. 13, 14 patient GCS, yeah.
Yeah. So the patient is unwell clearly, and it could get worse with these findings. So I would discuss my findings with the stroke nurse and the stroke team, and also this patient will likely need on-table angiogram, like conventional angiogram of the circle of Willis, and also all of the arteries to demonstrate where is this bleeding coming from. I couldn't see any aneurysmal lesions in the on top of my assessment for the circle of Willis. I couldn't see any obvious aneurysmal lesions, but then on the on-table angiogram, that would be assessed further, and also if there is any peripheral aneurysms, it will be assessed further.
So what should be your next? You are a registrar on call. You get
Yeah.
this patient in the middle of the night. What are you gonna do?
So in the middle of the night, after discussing with the stroke team, I will basically either discuss myself with the interventional neuroradiologist on call, and basically convey that this patient have a large hemorrhage. It is subdural and also subarachnoid. I couldn't find any aneurysmal lesions in the contrast enhanced study or in the CT angiogram, but this patient might need on table a conventional angiogram to elicit the lesion from which they are bleeding. And I will also mention that the GCS is now 14/13 and the patient is unwell, so this needs to happen as soon as possible.
Okay. Thank you. The next patient you're gonna get, patient is complaining of flank pain. Okay.
Okay.
Mm. I'm going to give you control. Please accept it.
Yep.
Thank you. Yeah. You're
So
free to scroll now. Thank you.
okay. Is that me who's doing
Yeah,
the
yeah. So it's yeah. Basically, don't right click. Just left click and then drag. Sorry, no, not like this. Just a second, please.
okay.
Just a second, please. You we have enlarged the image, right?
Yes, yeah.
Let me reset it now.
Right.
Okay. All yours now. Thank you.
Okay.
No. Yeah, hang on. Okay. I think you're right clicking rather than left clicking.
Sorry,
Please.
I'm doing it.
You're right clicking then left clicking, you know. So
Um,
I would suggest you please use this scroll bar on the top of the image rather than scrolling it through your mouse. I think at the moment you're scrolling through your mouse. So it's better if you just just drag it along.
yeah, I'm using a MacBook, so I'm just using the mouse pad rather than an actual mouse.
Yeah, that's better. That's better. That's what you did. You did the right thing. Yeah, that's one.
Okay. So this is an axial cuts of a CT abdomen and pelvis non-IV contrast, but then I can see there is probably an oral contrast that's gone into the small bowel. What caught up my eye is a lesion on the left kidney, but now
I'll scroll for you. I think you're changing the size of the image every now and then.
I'm sorry if you can
Oh, it's
scroll.
fine. It's fine. Don't worry. Don't worry.
Yeah.
Let me scroll for you. Okay.
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 Yep. So I can see a large lesion in the left kidney. So it starts at the upper pole and it has the close sign, so it looks like it's coming from the parenchyma of the kidney itself. I just now want to assess, it's compressing the renal parenchyma, but then I can't see an obvious hydronephrosis. I now want to assess the left ureter going down. I'm actually looking at the left ureter as we go down, and all the way. Yeah.
Until here, that's it.
Yeah, okay, no problem. I will just assess the contralateral side. So the right kidney appears unremarkable. There's no signs of hydronephrosis or hydroureter. Just looking quickly at the rest of the organs, if I can just look at the liver, please.
It's fine. Liver is fine. Don't worry about it.
Okay, then. So this is a large mass in the right and the left kidney, which is causing hydroureter, and I can't see the bladder, so I can't comment on the rest of the urinary tract. But then I'm concerned that this could be a syncytial pathology rather than just a simple cyst, especially with the close sign and with the compression of the renal parenchyma. So what I would do if this patient was still in the radiology department, I would request for a CT abdomen and pelvis with IV contrast, and take it from there, really. I would also assess the bones, because if this is a renal cell carcinoma, it could have lytic bony lesions if it's metastatic, and I will also complete my... Sorry?
You have got this. I've given you now with the contrast.
Okay, so this... Okay. Right. So I can see now just on the slides without scrolling, but I'll try to scroll again.
I can scroll for you if you want.
Yeah, okay. So this is a large cystic lesion, again centered in the left kidney, with a close sign, and I can see that the left renal vein is quite dilated, and it's a bit heterogeneous. It has a bit of a heterogeneous enhancement, or it's dilated. Okay, continuing the assessment to the rest of the renal tract, I just want to see the bladder as well, if that's okay. Yeah, so the bladder is roughly unremarkable, but there's if the bladder is completely full, there's a bit of thickening in the posterior wall of the bladder. But anyway, I think the main pathology is actually in the left kidney. And I think it is a sinister pathology, and I'm concerned that this is a malignant process. So what I would do is I would refer this patient to the urology team, and also to be referred in the renal cancer MDT after obtaining a tissue diagnosis. Likely it would be CT guided tissue diagnosis from this mass. But this mass is actually really large, so I don't know whether the urology team would prefer to just perform an nephrectomy to know what kind of a tumor is this. But this will also depend on how much this kidney is functioning. So I wonder whether if they want to save the kidney, they would do something like a MAC3 scan or a DEMSA scan to elicit how much is this kidney functioning. But I feel like this kidney will likely come off because of this lesion, and I am also concerned that the left renal vein is thrombosed secondary to this mass lesion.
Okay, thank you. That concludes your webinar.
Thank you.
So, how did it go?
I don't know. I sometimes think of lots of ideas, but I sometimes feel like I need to rearrange my ideas before speaking. I don't know. I'll let you tell me.
Okay. So we'll get first concentrate on feedback, and then I'll give you a personal feedback. Okay.
Okay.
So in this case, that's the first thing I gave you, non-contrast CT. So you mentioned close sign. You were talking about close sign a lot. And then what can you see here is basically you even on the non-contrast CT, you can see the thinned out renal parenchyma. Can you see that?
Yes. Yeah.
Yeah, and then you can see the ballooning of the, you can see these ballooning of the, or blunting of the pelvic vessel system.
Yeah.
So it's a huge renal pelvis and
Yeah.
significantly dilated ciliaceal system throughout the, and then what's happening is this renal pelvis is converging to a point basically, and then there's a sharp transition point between the renal pelvis and the ureter, and then nothing happens afterwards.
Yeah.
The fact there's no fat stranding around it, the fact that there's a very sharply demarcated renal parenchyma, which is very clean, you can draw a pencil around it with a pencil. And the fact that the margin of this cyst, or even on the non-contrast CT, is very thin. And then always ask for contrast enhanced CT scan whenever you come across a suspected lesion or even a lesion, So never settle without. If the examiner say, yeah, we don't have it, then that's a different story. But if you don't ask it, you don't get it. You don't ask for it, you don't get it. Simple as that.
Okay.
I'm just telling you from my personal experience. So very personal bad experience. Okay. So here you can see that left kidney, again, a post contrast, the parenchyma is very thinned out, So I agree with you. This kidney has almost lost its function, just on the basis of this CT as well. I haven't done any nuclear study.
Yeah.
But you can see very little renal parenchymal thickness is left. All you
Yeah.
can see is this is a clear, here you can see clearly pelvic lysoid system. It's a clear case of PUJ obstruction, pelvic junction obstruction.
Okay.
Yeah. And then once you see it, then you ask for a excretory phase scan. Then you need to demonstrate whether the contrast is excreting through it. First of all, whether there's a contrast being excreted, and once the contrast is excreted, whether it's crossing the PUJ. So basically, even on this, I can say the PUJ obstruction, a large PUJ obstruction, and nothing else.
Yeah.
No other findings in this. No other. Yeah, prostate is a bit enlarged, but then nothing else. Nothing else here.
Right.
And next step you do is MEC3 or renogram.
Mhm.
And then just to find the functionality of the kidney. So just for the audience interest, I mean, I wanted to show you once I wanted to first diagnose it properly, then you ask for renogram. Without that, it's not fair to give you renogram. Can you see that?
Mhm.
Or no?
So is that a Mac 3?
Yeah, that's MEC3 renogram.
Yeah.
So what's happening is,
So the right kidney is doing all the function, and the left
yeah,
kidney.
because the posterior projection, so this is right kidney and that's the left kidney, so left kidney is not even up, there's no uptake.
Yeah.
Uptake is a word, yeah. There's no uptake there of nuclear tracer. There's no
Yeah.
uptake.
Yeah.
And then here as well, you can see there's uptake in the right kidney.
Yeah.
But then there's no uptake, flat line. It's a flat line. There's no uptake.
Mhm.
It's a renogram you can get in an exam. So at least you can be familiar with that.
Mhm.
Okay. And you may be shown this, or you may be shown this,
Yeah, this is a
okay.
yeah,
So as you go along, the photon count, the count basically increases anyways. So
Yeah.
I mean, unfortunately, I mean, this case, if you say sinister mass and all those, unfortunately, you are not going to pass this case
Hmm.
clearly.
Okay.
You may get clear fail or you may get borderline fail here.
Mhm.
So moving on to the next one. Yeah. That's the one. Now, let me share the screen. In this case, I'm slightly concerned. So here, I mean, see, you may not have seen it. So I'm giving you the benefit of doubt. But the thing is, first of all, you recognize it very well. It's a post-contrast CT, yeah?
Mhm.
And you recognize it very well that it's a, and then there's enhancement. You use the word enhancement. And when you use the word enhancement in the dural lining, and then I was like, okay, she's going in the right direction.
Hmm.
But then eventually you said that there's a subarachnoid hemorrhage. Did you say that, right?
I said that, yes.
Yeah, subarachnoid hemorrhage. So now basically it's a contrast enhanced CT scan. Yeah, these are the vessels. Yeah, a subarachnoid hemorrhage is going to be here. If it's a hemorrhage, if it's a hemorrhage, what kind of hemorrhage is going to be? Yeah,
Yeah.
subdural hemorrhage. Okay, if it is a hemorrhage.
Yeah.
So hemorrhage is never like lobular. It's very lobulated, right?
Yeah.
You can see that it's a thickening. It's a lobular thickening,
Mhm.
nodular thickening of the dura or
Okay.
meninges. And these are enhancing avidly. I didn't give you pre-contrast scan, basically. I gave you only post-contrast scan. And the answer I was expecting from you is that there's a lot of, edema around it. There's kind of some midline shift, a little bit of then effacement of the lateral ventricle on the left side, all because of mass effect from the nodular enhancing thickening of the dura. These are what
Is
patient
it
is patient is
or
having. So you next thing you ask is these are likely sinister lesions. But I want to know the age of the patient.
mm,
Has it got any background history of malignancy? Could this be metastatic? You know, all depends on the age. And by the look of the parenchyma, I think the patient has got involutional changes. It couldn't be a young 40-year-old, 30-year-old patient, this one. Okay. So
okay.
now look at the skull. What do you see? Sclerotic
Oh,
metastasis.
there's some
Yeah.
sclerotic mets. Yeah.
Yeah. So skull is full of sclerotic metastasis. This
Yeah.
correct? Yeah. So and on top of it, you have dural metastasis. So it's a prostatic cancer patient.
Mm-hmm.
Could be a breast cancer patient as well, but this is a prostate cancer patient. But anyway, the thought process I want to tell you that in contrast can just be wary of the enhancing metastasis.
Mm-hmm.
You will get a sharp margin in the and that's first, and then the case before that was yeah, that's the one. That is the one which I okay. Can you see that image?
Yeah.
So here, basically, it's a child. It's a child. It's like probably 12 years old, maybe. You know, that's the scrotum, and I can see that's the penis, and that's the scrotum.
Mm-hmm.
So and that's normal.
So is that
No,
okay?
no. What I would have loved to see that even if you don't say anything. So the way you approach is, for example, you sit back and you see what could be the pathologies in a limping child in this age group.
Mm-hmm.
And then you approach the case accordingly. Obviously,
Mm-hmm.
examiner is not going to tell you which side the limp is, you know. Then he's going to give you the answer. So you see, this is quite normal space. This is widened. On the left side, slightly widened. I may be telling you because I know the answer. Okay, suppose you can't find out, then what is the next step? The next step is frog-leg view.
Mm-hmm.
You never forget orthogonal view. Never. The moment you ask for frog-leg view, examiner is bound to give you, but you have to earn it.
Mm-hmm.
You have to tell examiner, why do you want frog-leg view? What are you suspecting?
Mm-hmm.
You just can't say, can I frog-leg you, please? You can say, okay, this is a immature skeleton of a child probably, or 12-year-old, and or early teens, and I want I can't say anything. You can say I can't say anything. I'm trying to see whether there's a widening of the faces. I can't see. I'm trying to see any fracture. I can't see. The height of the femoral heads are normal. I can't see any depression. I can't see sclerosis. Just to rule out avian. Because we talked about avian a lot, you know. So look at the femoral head margins. Very clear, very clean. And when you do frog leg view, you can see the, widened. It's a left-sided Sufi. Full stop. Next case, that's it. So in your case, I would say you need to practice a bit more, I would say. Your communication skills are good. So you talk good. You talk well. Whatever you say, you go say with confidence. So that's a good aspect. But I would suggest, honestly, to see more cases, I would say, and try to see a lot of x-rays as well. So practice. I think practice, practice, practice.
Okay.
You will do it because your communication skills, the way you talk is good. So all you need is practice. Okay.
See.
Thank you. Candidate 4, please. Thank you.
Hello, Dr. Imran.
Hi, Kenford. Are you online?
Yes, I am. Can you hear me?
I can hear you. Thank you. So we will overrun a bit.
Mhm.
Patient is complaining of chest pain for quite some time now. Okay. I'll share the screen with you. I don't think you need mouse here. Okay.
That's fine.
Can you
I
see the
can't.
image?
No, I can't see the image yet.
Can you
Okay.
see?
Yes, now I can. Yeah. So I've been presented with a chest radiograph for a patient who has presented with chest pain for a while now. I will just briefly go through the radiograph before I start describing my findings. So there is a soft tissue density in the right uh, lateral margin of the thorax. This has got a well-defined contour medially and makes an obtuse angle with the lung. So this could be a pleural-based lesion. Apart from that, the mediastinum is normal. There is no pneumothorax. Bilateral hyalopia normal. I cannot appreciate the cardiophrenic angle. So I would, in my normal practice, I would ask the radiographers to have another view to look at the cardiophrenic angles. But so far, it doesn't look that the patient has got large pleural effusion.
Is it better or?
Yes, now I can see the left and the right. Yes, the cardiophrenic angles appear normal. The extrathoracic soft tissue is normal. Um, I'm looking for any bony abnormalities. There is no bony abnormality. So I can't appreciate the right scapular border as well as I could see the left scapular border. However, to summarize, I have seen a right pleural based mass with probable extrathoracic extension. I would like to recommend a CT thorax for this patient to further evaluate this lesion.
Okay, what could be the differential here at this stage?
At this stage, in terms of pleural-based lesion, this could be a pleural fibroma because it's very localized. I would expect a mesothelioma to give me a more rind-like opacification. This could be a loculated pleural effusion. However, in view of there is the cardiophrenic angles are normal, that is less likely in my diagnosis. The other thing could be a neurogenic tumor like a neurofibroma or a schwannoma arising from the intercostal nerves.
Okay. Okay. Anything else?
I would like to review this on a CT
Okay.
thorax to further characterize this lesion.
Just a second, please. Just a second. Let go of the mouse, please. I'm just trying to, yeah. Okay. You can scroll it now. Thank you.
It's not
Can you?
it's not scrolling for me yet.
Just a second. Just a second, please. Let go of the mouse.
Yes, sure.
It's scrolling for me clearly. So try it now again.
Sure. I can use the bar maybe. No, it doesn't scroll for me at all.
Leave it for me. Leave it. Okay, I'll scroll for you, just for the
Okay.
interest of time. Okay, we'll start from apex.
Okay, so I have been provided with the CT thorax lysis in a bone window as a follow-up study for the patient's chest radiograph. I can see there is a broad pleural-based soft tissue density lesion in the right lower lobe. Sorry, can you please go to the lesion if possible?
That's what it is.
Yeah, if you can just stop at the lesion if possible.
You can take the mouse now if you want. Thank
Mm, I'm
you. I think you keep pressing Zoom button, so I don't know why. Anyway, just a second, please.
Yeah.
No, let go.
Yeah.
Okay, now try.
Yeah. Still no.
Leave it then. I would say.
Stop remote control. I can ask for the control again.
Okay, now concentrate on this. Okay.
I can see the abdominal slice on this window. Is that what you want me to concentrate on?
I mean to say this sequence,
Mm.
this window. Just leave it for me. Okay, I'll scroll it for you.
Sure, thank you.
Okay, there you go.
Yeah.
What can you see?
So I can see there is a destructive lytic lesion, which is destroying the underlying rib. It's extending into the right. It's extending into the right extrathoracic tissues, and sorry, it's just flipping for me. It's not.
Okay, I don't know. I think from mine it's absolutely fine. So I don't know. Maybe connection issue. I don't know. Can you please try again? Because if you do it, it's better than me helping you out here. You can scroll the bar. Try going the bar.
Yeah, I'm trying. It's not working for me.
Okay. Try again now. Okay, I don't think it's gonna work for you. I don't know why, but
Yeah, I'm sorry.
no,
Why?
don't worry. I think I'll have to help you here. Don't worry. So
Sorry.
okay, that's fine. So what can you see here?
So, sorry, the lesion is not visible to me, so I can't.
So you can't see anything.
So now I can see. So there is a lytic lesion in the right rib, and it's extending into the right lung base and also into the extrathoracic tissue. Can I know the age of the patient? If this patient is elderly patient, my primary differential for this lesion would include a metastatic lesion.
Patient is 85-year-old.
Yes. So in an 85-year-old, my primary differential would be a metastatic lesion. I would expect, I would look at the lungs in the lung window to see if there are any lung, if there is any lung malignancy. I would look at the mediastinal lymph nodes to see if there is any mediastinal lymphadenopathy.
There's no mediastinal lymphadenopathy.
Okay, I would also look at the hilum, the supraclavicular lymph nodes, axillary lymph nodes.
There's no lymphadenopathy.
Okay, and sorry, because the skin is flipping, I'm just asking you if there is any lung lesions, any suspicious pulmonary
I think
nodules.
this format is not going to work like this, and honestly. So basically, we'll try another case as well.
Sure.
Uh, what else on the basis of this? What else you would like to consider here, diagnosis wise or differential?
So with a lytic lesion, I would also look at the abdomen and pelvis to see if there is any other primary.
Abdomen and pelvic are fine, clear. They don't have anything except gallstones and hernia.
Okay. In terms of lytic rib lesions, this is an aggressive lytic rib lesion. So osteochondroma, osteosarcoma will be my other differential, or a plasmacytoma if this is a solitary lytic lesion in the ribs.
Do you want to scroll now? You want to try scrolling one last time?
Yeah, I can give it a try. I'm sorry. I don't know why it's not working. It was just working fine before.
I think you keep pressing something somewhere else. It brings your screen to Zoom home. So something's wrong.
It's not showing to me that I'm going on Zoom or
No,
anything.
I think there's some. Okay, leave it then. I'll give you another case. We'll
Okay.
come back to it. We'll see with that work.
Sure.
Yeah. Okay. What can you see?
So I can see a pelvic radiograph.
Okay.
Is there any history for this patient?
This patient came in. Patient fell from horse.
Okay, so I have been presented with a pelvic radiograph for a patient who fell down from a horse. Is this the oblique view that you want me to concentrate on?
I'll give you a few views. Just have a look at them,
Sure.
and then I'll ask you a few questions. Okay.
Okay.
So what's happening here?
So I can see there is a lytic lesion in the right pubic not pubic symphysis, right ischial bone. I'm looking for any
So
cortical discontinuity.
what is this procedure called?
Oh, I have no idea. Sorry.
Just describe the finding.
So, I can see there is some increased bone density in the right ischial bone, and there is some cortical discontinuity. I can see there is a
Now,
tube.
can you see
Uh,
anything?
Oh, yes, now I can. So I can see there is catheter going into one of the tubular region, most probably a vessel, and I can see the contrast passing through the vessel, and there is some contrast leak at the end of the vessel. Um,
Yeah.
so maybe this is going into the urethra and to check for any urethric injury associated with the pelvic injury. I can see some extravasation of the contrast, which would be in keeping with urethric injury, I believe.
So which is the vessel you're talking about? The catheter in the vessel.
But initially, I thought that this might be a vessel, but then the orientation, it's going along the direction of the scrotum and then up. So I would like to retract my statement that it's within a vessel. It's to be within a vessel. It's in the urethra, I think. I can see it passing through the penis. So I think there is injury in probably the posterior part of the urethra.
And
With contrast extravasation. So I would alert the clinical team about this finding and recommend urgent urology referral for this patient.
what is this procedure called, or this examination called?
Uh, Retrograde urethrogram.
Okay, thank you. Okay. Limbing child.
Okay. I have been presented with a pelvic radiograph for a patient who has presented with limping pain. The left femoral epiphyseal head, it appears more dense than the right. I think there is some loss of height as well. I would, in my routine practice, I usually review this on frog-leg view as well. There is no fragmentation or irregularity of the femoral head. However, in keeping with the increased density and reduced height, my primary differential at this point would be a Perthes disease. I would alert the clinical team about the finding and recommend an orthopedic referral for this patient. So the frog-leg view confirms the finding of decreased height of the femoral epiphysis and with some cortical irregularity on the superior aspect.
Okay.
So I would recommend an orthopedic referral for this patient for further management of avascular necrosis.
What happens? How many patients would have bilateral AVN?
So bilateral AVN is usually 10 to 15%.
Okay. And you do anything else to any more examinations to confirm that?
I would recommend MRI examination to confirm the findings.
Okay. One last case. patient was complaining of some cough, you know. Oh. Okay, just let me share. Hopefully you will be able to scroll this one. Hopefully, fingers crossed.
It's the same.
A second. A second. Can you see that?
Yeah, I can.
Can you scroll? Oh yeah, you can.
Yeah.
Good.
Yeah. Sorry, can you repeat the history if that's okay?
The patient has been complaining of cough.
Okay, so I have been presented with CT axial slices for a patient who has presented with cough. Okay. I think it has stopped scrolling again.
Just wait, please wait. Just a second, please. Let go the mouse. Can you see?
Yes, I can.
Now you need to take control of the screen. Yeah, that's better. I think what you're trying to do is drag. I would suggest still the bar is better because I can see you're moving the images upside down all around the screen. I can help you with that if you want, but yeah, please feel free to scroll. Yeah, thank you.
Yeah, now it's scrolling. So I can see there is some consolidation in the left lower lobe. However, I would like to see lung window to look at this in further detail. So there are some lobulated there's some lobulated opacity in the left lower lobe, along with some train bud nodularity. This appears to be in contact with a lot of pulmonary vessels. In view of this opacity, I would like to review this on mediastinal windows again. And if we have any contrast enhanced images in the arterial face, I would like to look at the supply if it's coming from the thoracic aorta. My primary differential at this point is bronchopulmonary sequestration.
A second, please. Just a second, can you scroll now? If you can.
I can't see any image.
Okay. Good. Can just let go the mouse, please. Okay.
I can just see. Yeah.
Wait, I think what we have to do is. Yeah. Yeah, we don't don't know why it has completely disappeared. Whether the contrast phase has been touched upon or what. You're right. I can't see the image at all as well. Let me change the case then. If we can't, it's a good case though. Let me see if I can just bring it up again. Oh, blackout, complete blackout. So what was your initial suspicion there?
A bronchopulmonary sequestration.
Okay, and on what basis?
So because there was a soft tissue density, and it wasn't a consolidation. There were no air bronchograms. It had quite lobulated appearance. So that's why I thought that this could be a bronchopulmonary sequestration.
Okay, so on the basis of just lobulation?
Um,
You think?
and the density, there were no air bronchograms or any surrounding parenchymal changes like hemorrhage or any ground glass changes to suggest infectious changes.
Okay. So now I'm scrolling in front of you. Can you see?
Yes, I can.
So you wanted to establish a supply from?
I wanted to establish supply from the thoracic aorta.
Okay, so what can you see?
I can see there is a artery going from the aorta into the soft tissue lesion.
Okay, so
So this
so
would and then I would also like to see if there is any venous drainage from the pulmonary veins to classify into intralobar or extralobar pulmonary sequestration.
okay, what can you see? So
I can see it's draining into the pulmonary veins. So this is intralobar pulmonary bronchopulmonary sequestration.
Okay, what do you do then? Next.
So since the patient has presented with cough, there is a possibility of some ongoing infection along with the sequestration. However, I did not see any air fluid levels or the gas locules within this to suggest infection. Uh,
Yeah, it's better to see gas
there,
locules
there is,
on lung window rather than mediastinal window. Yeah.
there is some gas locules within this. So this would be in keeping with
No,
the
there's no gas locule. No, you're right. There's no gas locule.
so I would recommend a respiratory team referral for this patient. Usually they are managed by excision.
Whatever, if I say patient is 60-year-old.
Then they would just not do any surgical excision. They will just observe this and treat the infection with the antibiotics.
Okay, thank you. So I think, sorry, your session was a bit spoiled with this technical. I don't know why it was happening, but so yeah, you first of all, let me comment on your style and the way you are approaching the case, and then we'll go through the case.
Sure.
You're an excellent candidate, I must say. And you take your time, and you, I think you have got very good grasp of the subject. The way you speak is very good. One observation, which is not criticism for the sake of criticism, I think if you could improve yourself, you speak with a bit of uncertainty.
Okay.
So when you say it's a bit of that, it appears like that you are posing a question to the examiner rather than giving an answer at times. I just
Yep.
felt like it. So in a mock situation, when you're practicing with your colleague or your consultant in the hospital, it's okay because then you look at the consultant face for a nod,
Yes.
and then we get a positive reinforcement, and then we move on. In exam scenario, you just are, facing masked faces. So
Yep.
there will be no emotions or no affirmations, or
Yes.
So I think if you are, I don't know, I mean, to be honest, what kind of how you expect, but you just need to be a bit more firm in your what do you call it, sentiment of your or tone of your
Sure.
answer.
Got
Uh,
it.
you're giving the right answers, but there is a bit of you're probing, slightly probing. Your answers are slightly probing. That
Okay.
so remove that from that. I think the expression of probing is a bit there, which I've noticed in all your answers, not in this case, other cases as well. Actually, you are answering it and answering it rightly, but then I felt that you're asking me a question.
Okay.
So just try to just take it away from the. Otherwise, your approach is excellent. You're very calm. You don't lose your plot, despite the technical glitches. I thought you will just mess up with this when you were saying consolidation, and suddenly I think you just said that I want to see the connection with the aorta, and I was like, okay, so she's got it basically. So this is the intralobar pulmonary sequestration. If patient is old, if the patient is not having any repeated infection or patient has lived for 60 years, then probably they will leave it. In young patients, when then there's a repeated infections, and then obviously there's a cause of concern. So that's a case of intralobar pulmonary sequestration, where you will see the connection or the arterial supply from the thoracic aorta directly systemic supply. Next one, before that, now remind me, because there was a lot of, oh yeah. So that was a bit, I won't call it funny, but I was like holding my head and scratching my head, to be honest, for a moment when you start talking about, just a second, let me bring it up. Contrast in a vessel.
Yes.
So that
I
was a bit.
I just looked too deeply into the
I
screen.
was like, maybe she hasn't seen it in her life, this urethrogram or retrograde urethrogram or what. Let me share the screen with you. But then again, you quickly recovered afterwards. So that was very commendable. So it's like a plain control film you do AP, and then you can say it's a pelvic AP radiograph. And then examiner will tell you that, okay, we're gonna see you a series of images. Have a look at them and let us know of your thoughts. This is how they approach it. And then they start showing you this series of images. And then after seeing that, you just hold. Can you see that? Yeah.
Yes, I can.
Yeah. So basically, what you do is just grasp it. If you don't know it, just think about it. How you are going to approach it, rather than just throwing that it's a contrast in a vessel, and the extravasation of contrast through a vessel. So, but then if you don't know the case, then try to orient yourself with anatomy.
Yes.
It's kind of an oblique sagittal, then or lateral view. Then you can say soft tissue. Soft tissue and bones are your friend. Then you say, okay, it looks like a penile structure, penis, and then there's a hip. So maybe it's an oblique projection, and then there's a catheter coming in, and then it's going to urethra. So then obviously there's the urethra, and then there's posterior. It's a horse-riding patient I mentioned to you. So horse-riding patients are quite, this kind of urethra injury is quite common, bulbar urethra. Okay. So there was a contrast extravasation. So if you go to the very last, see, there's a lot of contrast extravasation there.
Definitely.
So that's it. So when you don't see, if you're challenged with an unfamiliar case, don't just panic and start saying vessel or what God knows what, just sit back and try to give yourself a chance. And I'm sure you being a very excellent candidate, I'm sure you will do it. Before that, then we had yeah, AVN was that was very easy, Percy's case was very easy. I mean, it was a accident. So and then first case, yeah, I would say first case could have been done better. So let me just show you the first case. Okay. Now, for the interest of audience as well, can you see this? Can you see this chest X-ray?
Can't see the screen yet. It just says you're sharing the screen, but the image hasn't come up. Now it has.
So it's there, yeah?
Yes, yeah.
Okay. So you mentioned that there's a obtuse angle, a pleural-based lesion, absolutely fine. Then you said there's no bony abnormality. Now, if you just look at it, it's so quite common. People miss it, I mean, it's quite common. So so I'm not windowing it. Okay, this is how you got it. Okay. So 1, 2, 3, 4 posterior ribs. 1, 2, 3, 4, 5. Where's the posterior rib gone here? So there's a gap. Posterior rib, posterior rib, posterior rib, posterior rib. Where's the posterior rib?
Yes.
And then posterior rib. So this rib has been eaten away. So there's rib dissection. So you could easily say that if you compare, always compare from the contralateral side. Here you can see rib, 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 rib. Where's the rib? It's gone. I can't see the rib.
Yes.
So basically, this rib has been eaten away, a destructive lesion. So you can say it's most likely it's based in the rib. It's a destructive lesion. It's extending to the extrathoracic soft tissue. You can see the density of the soft tissue here and density of the soft tissue here. So you can extract a lot of information from just X-ray. And then you can ask the age of the patient. And if the patient is elderly, then you can say, okay, metastatic lesion is my first diagnosis, my first differential. Second differential could be in this age group, could be plasmacytoma if it's a solitary lesion. Or it could be anything else as well. But these are two top differentials. And then you move on for the CT scan. You move to the CT scan, and then you get a lot more information, basically. So in CT scan, what I would have loved you to basically ask me is bony window. Why? Because, let me share first. Because once the lesion is destructing a rib, then you, by default, you're going to ask for a bony window by default. If you don't ask for bony window, it's a crime. Somebody, even in metastatic lesion, you get one metastatic lesion, you can get multiple metastatic lesions. You get one plasmacytoma, it could be multiple myeloma. So not asking for a bony lesion is criminal, it's a sin, it's a crime in exam. Don't do it. You didn't ask for bony window.
Right.
See, it's a rib-based lesion.
Yes.
Simple as that. And then soft tissue component going into the, thoracic cavity, and then pleural, it's involving the pleural muscle wall, chest wall. And then obviously these are secondary changes in the lung. Now, what else you can see here? I want you to find out what else. So see, what's there? You find one lesion, you find another lesion. Can you see that?
Yes.
In the sternum.
Yes, I can.
If you find second lesion, then you will find many more lesions.
Yes.
Keep looking at the spine or vertebrae.
Okay. There is another one, yeah.
So So what is the see what's there? So there are loads and loads. Look at the pedicles.
It's gone.
Yeah. So what is the differential now? Completely changed. What is the main diagnosis here?
Multiple myeloma.
Multiple myeloma. So once you say it's most likely multiple myeloma, although these could be metastatic lesions from unknown primary, but my first differential is multiple myeloma. And I would like to evaluate further in our hospital. We do MRI of the whole body or MRI of the whole spine. So I would have given you MRI if you had asked for MRI. Just for the now, since we have spent a lot of time here, let's complete this case by looking at this MRI. Okay.
Sure.
I'm sure you guys have seen that, but let me share. Can you see that? Not this screen. Okay. Can you see the screen now?
Yes, I can.
So what sequence is this?
So this is T2 sequence.
It's a stir sequence. Can you see the fat?
Yes, it's stir sequence, T2 fat
Exactly.
spread.
Yeah. So what is the hallmark? What is the salient feature of this?
So it's involving whole of this vertebra, all the vertebrae with
What do you what word do you use? In my practice I use the skeleton. The visualized skeleton is riddled with it's completely riddled with. I use the word riddled with. Small hyper intense foci or lesions throughout the skeletal visualized skeleton. So basically marrow has been replaced by all these. So it's multiple myeloma. It's classic multiple myeloma. Okay. And the patient gets referred to where?
to hematology MTT.
Yep. Yeah. So basically, in this case, I would give you just pass.
Okay.
Because you got the diagnosis, plasmacytoma with metastases, but it was a bit of turbulent ride. So I would give you just pass here. Okay. And just pass is what? Just pass is what? As per our presentation.
It's like
So we need to get used to of the marking scheme now.
yes.
Okay. So scoring saying just pass is 2. Clear pass is 3 and excellent is 4. So you got 2 here in this
Okay.
patient. Okay. Okay. So overall, I would say you are an excellent candidate. You handled all the cases well. Just a bit of uncertainty in the answers. While you knew the answer, you were telling me the right answer with uncertainty. Just take this away. Okay.
I'll work on it.
Otherwise, I'm very happy with how you have approached the cases.
Sure.
So thank you very much, guys. Don't forget to fill the feedback form as usual. The more the merrier. And just review the website and just get used to of whatever mock you do. Try to score yourself with the new marking scheme. Okay. Thank you. Good night.